Basically what I'll be trying to do is to describe the double burden of status in our country, in India. It's more closer to home right now. And then the effort is to emphasize the need for an integrated approach and to think about the seemingly divergent problems of malnutrition as problems that are closely tied together, and to look at what are the policies that are available in the current Indian context that can be leveraged for the double duty action. And you may see that there is some repetition from the earlier talk, but I'll just quickly zip through some of these slides. So to start off, to characterize the double burden of nutrition, under nutrition, it can be at the individual level. It is, for example, it could be stunting. We are looking at stunting and anemia or undernutrition, and then obesity among the same individual. Or it could be related to the diet and non-communicable diseases. It could be within a person, within a household. Grandfather or a grandparent could have non-communicable disease, and in the same household, a child could be stunted. And it could be spread in the region. At a regional level, there could be a high proportion of stunting as well as high proportion of overweight women in the same region. And then this has a temporal aspect as well. It could be across throughout the life. Today, a stunted child can become an overweight or obese adult with non-communicable diseases. So if you look at the prevalence and trends in India currently, there has been India has had multiple forms of malnutrition. In the past 10 years, stunting has, at the individual level, under children under 5 years, stunting has declined from about 48% to now it is at 39%. Wasting has marginally increased. Anemia has declined, but it is still around 50%. And overweight has slightly increased. So here itself we see there are multiple forms of malnutrition right there. At the if we look at the women's nutrition, women of reproductive age, anemia is still very high. There has been a marginal decline. Underweight has declined definitely, about 10 percentage points, but overweight has increased. More than a third are now overweight or obese. Look at the men, again, anemia is around the same, about a quarter of men, 25% of men are anemic, and then overweight or obesity is at 35%. So more than a third of men and women in India are currently overweight or obese, and then around 40% of children are stunted. And not to say that these are all the national trends. This masks the state level variability, district variations, inequity, you name it. There are different, we can pass this through many lenses, and then we'll see the differences and variations there. And if we come to the dual burden of malnutrition itself, in women, at the individual level, women who are anemic and overweight or obese, it increased from around 9% to 15%. At the children level, those who are stunted and overweight or obese, the increase is very marginal. But at the household level, again, we see that among the mom and child diets, from 4.4% to the increase is now it's around 8%. But this, like I was saying, that the variability is, we can see here in the map of India how it is, the changes are. The left side map is 2006. And the right side is 2016. The dark red indicates the prevalence is greater than 20%. This is at the individual level, moms with anemia and obesity, the prevalence at the state level. So if we look at the left side, there are not that many red states. But as we moved to 2016, the color changed. So the lighter shades indicate lower prevalence and the darker shades indicate higher prevalence. Now, around 6 states in India in 2016 have more than 20% of women with the dual burden of anemia and overweight or obesity. And other states are progressing towards the trend. And here we look at this map shows the geographic variability of dual burden. This is powerful because if you look at the prevalence of stunting among children and overweight or obesity among women, the dark red color indicates the dual burden. The yellow in middle is the overweight only, which is prevalence greater than 20%. And the shade is a darker yellow color is prevalence of stunting greater than 30%. So in 2006, several states had stunting prevalence greater than 30%. But as we moved to 2016, the dual burden has increased. States like Tamil Nadu, was already dual burden in 2006, Tamil Nadu, Karnataka, and Punjab. Now we moved to 2016, the prevalence of the reason that Tamil Nadu has now is not showing as it has the dual burden because stunting declined. It's not, the overweight is still very high, but more states have become darker. And if we look at the UP and this particular area, it has the dual burden because the stunting is really high, and now overweight is also increasing. So this is just indicating the magnitude of problem and where we are moving. As we, in the next 10 years, states like UP where we can expect a decline in stunting, they still are going to move into the overweight, so they'll still continue to be in the red zone. And there are the emerging challenges of the burden of non-communicable diseases. The high blood pressure and high sugar levels among both men and women are now it's less than 10%, but we can expect them to be increasing with the rising trends in the overweight and obesity. So if we think of what are the drivers of the double burden of malnutrition, there are multiple drivers. At the biological level, alterations in gene expressions are likely to increase the risk for low birth weight, obesity, and overweight. And then the early life experiences in utero, which lead to stunting, can in later life lead to obesity. In the constantly changing food environment gives this kind of propensity for changing from undernourishment in the during early life to overnourished individuals later on. And the urban and built environment also contribute with the changes in the lifestyle factors, lack of spaces for physical activity also are contributing factors to the double burden of malnutrition. In terms of behavioral factors, we always say that the behaviors of individuals, which may or not always be conscious decisions, but are nudged by the cues in the environment, which eventually become habits and then lead to the food choices we make or the physical activity choices we make. And then there has been socio-demographic shifts in the patterns. For example, now the lifespan has increased, so with more older people, and there is a likelihood of non-communicable disease, burden of non-communicable diseases increasing. So there is the part that I want to focus on is the shared drivers of under and overnutrition and obesity. Poor adolescent and maternal nutrition, which continues today in India, can lead to the maternal anemia, maternal underweight and overweight, gestational diabetes, and all these have poor maternal outcomes later in life. And the poor fetal development, preterm birth, and low birth weight have poor early and later life outcomes. So what is happening now at this point has later life consequences, both for the current women of reproductive age, current pregnant women, and as well as children who are born now. And in terms of early life nutrition, stunting, wasting, we all know has increased risk for later life outcomes. It has implications for energy regulation, fat storage, and then later life NCDs. And when we think of the food environment, lack of access to quality food and inappropriate marketing can lead to poor child feeding practices. Poor complementary feeding practices has implications for stunting, but poor child feeding practices also has implications for the food choices that children make as adults, because the way complementary feeding unfolds can influence self-regulation among the adults. And then there are, continuing on the health environment, if poor quality of preventative care can lead to undernutrition as well as lack of screening for the non-communicable diseases. Carlos had given an example of ANC in Brazil is around 90%. Here we are still at 50%, 4 or more ANC. So we have to increase the coverage of the interventions that are still that need to address the undernutrition, which have scope to prevent the later life overnutrition. In terms of curative care, again, it has implications for as the diseases among growing children has influence on their growth outcomes. But at the same time, if we don't have treatment availability and appropriate systems for treatment, then management of non-communicable diseases also becomes a problem. And if we think of the living and work environment, poor water and sanitation facilities leads to stunting and increases diseases, again a burden on the health system. Poor built environment impedes physical activity. Social environment for infant feeding, if there are working mothers now, how are they able to do breastfeeding? Are there safe spaces? Are there social norms for facilitating breastfeeding and proper complementary feeding practices, which again have implications for both under and overnutrition. And poverty, it increases risks for all forms of malnutrition, which we still have a long way to go to address. So basically what all this calls for is a double duty of actions. And there are 3 key messages that the WHO policy brief calls for is do no harm with existing interventions. So while addressing single form of malnutrition using one intervention, try not to influence the other overnutrition side. And try to retrofit the existing interventions to do the double duty. And then try new interventions. So from that perspective, if we look at the policies and platforms intersections in India, what are available and what are the opportunities that exist. In the health system, we have all the essential nutrition interventions that exist for the undernutrition, to address the undernutrition part. So the need is to ensure that the universal coverage it happens and we close the inequity gaps. There is a national action plan for monitoring framework for preventing NCD. It exists, but what does that really mean? Where is the action for that? So the focus of the current health system from undernutrition needs to move and also start incorporating the overnutrition aspects. So we have to examine, do we have the infrastructure and human resource capabilities for managing the emerging dual burden of diseases? In terms of the food systems, we have integrated child development services, where the supplementary nutrition program for pregnant women, lactating women, and children up to 6 years. Now, in the context of the growing obesity numbers, the original intent of the program was to supplement through calories and protein food. But is this the time to re-examine the take-home ration and the one full meal scheme composition of how it can actually potentially lead to the obesity issues? If we think of the midday meal scheme, again, looking at the diet quality of that midday meal, looking at that is important. Is there a place to include micronutrients there to improve the diet quality? And if we think of the public distribution system, it is also heavily focused on the cereal subsidy. So is that what we want to know? How do we diversify the food basket through the public distribution system? So we have to reassess the composition and quality of all these programs that target our food systems. In terms of the nutrition governance and accountability, there is a national nutrition mission that has been announced, and it promotes integrated actions across multiple sectors, but the focus and the lens that it brings to is undernutrition. How do we think about it to make it more integrated approach that addresses the double burden? And we have to examine the existing governance and accountability mechanisms so that we hold the programs and policymakers accountable for the proper implementation of programs that address the double burden. And we cannot ignore, when we talk about double burden, the food policy in India, whether it is placed to address the dual burden or not. And here I take this from Anne-Marie's paper. The food supply, it's a critical factor for addressing double burden. There's no moving away from that. The common aid is diverse and quality diets. But food supply has multiple goals. There are economic objectives. It's about attracting investment. It is about economic stability. And what does it result in? It supports calorie availability and promotes foods high in sugar, fat, and salt. So some of the barriers that have been identified are technological, counterproductive policy initiatives that focus on food processing, resulting in highly processed foods, and then sense to maintain staple food price stability. And then long-term investments have been made to support the food policy choices, the infrastructure, the way it is done. So it's hard to rethink. So, but this is where our role comes in, to push the policymakers to rethink the policies and identify what are some better ways of influencing the food basket that comes to the household. And some examples of opportunities are small-scale agriculture missions directed at pulses and horticulture have been done. There have been investments in cold chain infrastructure, but can we move it more for fruits and vegetables? And then some small-scale public support process and package healthy traditional coarse grains has been implemented. So these all have been at very small scale. We have to study and understand how, if these are implemented at large scale, how can we improve the food systems. And finally, I would summarize to say that India is experiencing the dual burden, and we know there are multiple determinants. We have to address these several determinants. The primary need is that we all need to see the synergies between the problems and solutions for under and overnutrition. There are policies. What it requires is investments to manage NCDs, prevent rising overweight and obesity, and then shift the policies, food policies, from calorie sufficiencies and high calorie foods to diet diversity. And then finally, the nutrition governance is focused on undernutrition. We need to bring it back to look at holistically on malnutrition, not just undernutrition. Thank you.
Thank you.